going to be a cadaveric dissection video. I have a few slides. So this is one way to do it regarding the positioning. I will show some slides about the positioning that I commonly use. I sometimes use the flat position too, in supine position too. So in a bit chair position, how you can do it? Actually, you can do that any institution with any table. So you don't need a specific table. You just need to put the patient a little semi-bit chair, I will say. If you put them really in a bit chair position, like arthroscopy position, I think the anesthesiologist gets too excited about the blood pressure, then you get more bleeding. So, and you don't need it in these cases. One thing is that in this table, you got to pull the patient all the way to the side. The head needs to be at the edge of the bed, and I tape the head to the bed. So then to avoid the bars at the edge of the bed, then you got to tilt. But also to get a Grashy view, so get better glenohumeral joint view or better AP of the proximal humerus. Also avoid the bars. If you tilt the C-arm the way that you can see it, avoid it so you can see good views. And by rolling the C-arm from up down, so over the C part or the rainbow part, you can get both AP and lateral views. As you can see, you can get like a lateral view without moving the arm, and you can get an AP view of the proximal humerus by rolling the C-arm. And because you are tilted, actually the C-arm doesn't hit the table. So this is one way to do it. Again, you can do in the supine position, in this position too. I don't have slides for the specific time limitations. So you can do in this position too. When they are very simple, I do them in supine position, like a 2-part. When they are more comminuted, 3-4 parts, I do bit chair, but I think every surgeon has their preferences. So the most typical approach to use is deltopectoral, and I do almost exclusively deltopectoral approach, except isolated greater tuberosity fractures. Again, this is a surgeon's preference, and I'm going to be a little biased, and I will keep telling you this during the video too. The other one is the deltoid split, and there are different deltoid split. Actually, deltoid split can be done through a strap incision too, as you can see, which some people think that is a little more cosmetically appealing actually. And most commonly, deltoid splits in this country are done with the longitudinal incisions. It can be done in 2 separate ways, actually, to the middle of the split, or split between anterior and the middle deltoid. So we're going to go over this video on a cadaver, and obviously cadavers are easier to see everything. When you are operating on a real injured tissues, they are all red, and it's hard to identify. I mark the coracoid, and I go along it towards the insertion of the deltoid. I think you can make your incision smaller or differently too. I don't think skin incision matters as much because it's very mobile tissue, and you dissect subcutaneously between the fascia and the subcutaneous tissue, and you can move tissues around. The key is that to find the deltopectoral interval. Sometimes it's not that easy. Obviously, if you can find the vein easily, that's the kind of landmark for you. That's the purpose of the cephalic vein in my mind, to mark for you where to go. Sometimes it's hard, and you are kind of find yourself, it's almost always a little more medial. You keep dissecting, you don't know, you can't find the vein. Then the next thing I would do, I will go a little more distal, and to be able to see the basically interval between the pec major tendon and the deltoid. Is there any downside of making a split in some fibers of the deltoid? Probably not a huge. If you are not getting too much of the deltoid, then you are partially denervating the anterior part of the deltoid, which may work, especially in the revision cases. Sometimes it's hard to find the interval. Because of that, when I go out, closing, I put some ethibond sutures that in case any revision is needed, even 50 years later, you can find the interval there. Again, you got to find this subdeltoid interval. Feel the shaft, and you want to find this subdeltoid recess, right? Again, when you are putting your finger there in a fracture case, you got to be careful because there are going to be sharp edges. But this is the way that you need to kind of identify it. And this is this clavipectoral fascia, which a lot of times intact, despite even comminuted fractures, a lot of times it's intact. Once you cut through this clavipectoral fascia, again, they are usually nice and clean in an arthroplastic case, but in a trauma case, it's never nice and clean. So the next thing that up top is the coracoacromial ligament, the CA ligament. So I think it's okay to cut that ligament if you are going in reverse, but otherwise you try to keep it. You may detach some part of it, the anterior part of it, for exposure. The next thing is the lighthouse of one of the lighthouses of the shoulder, right? This is the biceps tendon. It attaches, it lies just underneath the pec major tendon. If I have the pec major tendon identified already, a lot of times for ease of exposure and also to mitigate the deforming forces of the shaft side, I may release the pec major tendon. As you can see, once you expose the coracoid, you can see all the structures. Again, feel the axillary nerve underneath the deltoid muscle is underneath there. For a deltopectoral approach, you don't have to worry. This is the beauty of the deltopectoral approach. Actually, you don't have to see the axillary nerve, and you don't have to worry it. You can feel it if you want to, but you're not gonna, the risk of injury is very small. So identifying the greater tuberosity is probably the most critical part in a fracture case. Where is that exactly the borders of the greater tuberosity? Because the cuff tendons are attached, also the displaced part in a displaced fracture. And we are not talking about two-part simple fractures. In a three-part or four-part fractures, right? Identify where that tuberosity is. And it's usually displaced, right? It's not like this in an arthroplasty case or in a cadaver. It is displaced. It's not sitting where it's supposed to be. It's usually displaced posterior and superiorly a lot of times too. This is the main critic of the deltopectoral approach, that it's hard to control, visualize, and control the greater tuberosity fracture. The way I get it, I get to handle the greater tuberosity displaced one. I put a suture at the leading edge of the basically supraspinatus, right? Once you identify the biceps, you go just posterior to it, to the bicipital groove, and you put a suture between where the greater tuberosity you think it is. Then you put a suture and you keep walking posteriorly along the greater tuberosity. That way, at least in my hands, once you develop this deltopec interval between the clavicle to the deltoid insertion, maybe a little longer skin incision than your arthroplasty cases, I was able to, so far in all my cases, be able to get this greater tuberosity piece. Again, it's not as easy as the deltoid split probably, because the deltoid split could be a more straightforward exposure to the GT, but I like more non-muscle splitting approaches. So that's why. As you keep going, and you go through the supraspinatus, infraspinatus, and down on the teres minor, I put all the sutures all the time, in almost all cases, because I want to have a good handle of the greater tuberosity. And if the greater tuberosity is displaced, you're going to need that augmentation with your sutures, and the sutures goes through the plate. Again, if needed to be, you can, if it's not already injured, your bicipital tuberosity area, again, the fractures, as you can see here, most of the fractures actually not along the bicipital groove. It's just anterior to it, but you can kind of incorporate and look at in the joint, or you can handle the head fragment. Because in a real 3-4 part fracture, it's usually not a surgical neck fracture, right? It's usually kind of an anatomical neck fracture, so the head is floating to a certain degree. It's displaced either in valgus or varus. So this is the biceps. If they are very comminuted fractures or there's some partial tear in the biceps, I usually take it down. And more elderly they are, I have no problem take it down and do a soft tissue tenodesis. So this is a kind of a valgus impacted fracture. That's in a valgus impacted fracture, the greater tuberosity is usually pushed out. It usually stays along where it's supposed to be, but the head is in valgusized, right? Through the fracture side with a bone temp or whichever device you want to use, you can push this head out of valgus. So once you push on the lateral side, when it's varus pattern, you need to get that cob or whichever instrument you want to on the medial side. And usually this is the fluoroscopy assisted. I usually put my instrument there. I want to know I'm medial enough and I'm not too medial enough because I don't want to disrupt the soft tissues more than needed. And I try to get the head out of varus. I am looking at it, but mostly it's a fluoroscopy assisted because unless you are looking on the medial side. So this is how we do the valgus extension. So deltoid split, again, for me, is a mostly, almost always is a isolated greater tuberosity fracture. So because I don't need to get the deltopectoral large interval, and it's going to be easier to control. I don't like the deltoid split because you are splitting a muscle. You don't want to be a splitter in general as a person. So why you are splitting a muscle? There are very few areas in our body that we do muscle splitting approaches, right? You make an incision. The mark that you see here is that where I think the axillary nerve is, the branching thing that I drove there. So it's about 5 centimeters. I drove with my marking pen every time. where to expect my axillary nerve relative to the lateral border of the acromion. That way I know where to expect. So then you start splitting basically the fibers of the deltoid. This is the more anterior split. And as you go in, the nerve is not going to be superficial layer. So I think it's the superficial layer is easier. So then you get your finger down, you will see a transverse structure which is more tighter than in a cadaver. Then you can feel it. Basically, the nerve, axillary neurovascular bundle is under the muscle when you go in there and above the fascial layer relative to the subdeltoid recess. And you can feel it with a blunt dissection. And you have to do blunt dissection here, unfortunately, and you can see that. I think one of the downsides of this approach is that if you need to go down there and you need to put a plate, you need to basically dissect a little more to release. And this nerve is not very kind of mobile nerve neither. So I think you need to dissect quite a bit, and a lot of times some of the vessels, venovasorum, may bleed around the nerve too. So then you reduce your greater tuberosity fracture and you apply the fixation of your choice. Also, you can get the reduction through this approach too, because there's some trauma colleagues that I know, they do deltoid splits for everything, every proximal humerus fracture. They tell me that we put the plate on the lateral surface, why to go anterior? Again, splitting the muscle doesn't make as much sense, and if you're going to have some degree of injury to the axillary nerve, and you're going to be denervating the anterior deltoid to a certain degree, and I don't like that idea personally. Again, this is the middle of the middle deltoid. Actually, I use that more often than for a greater tuberosity fracture rather than a splitting between anterior and middle, because I think it's a more direct approach. Again, you're going to be splitting the muscle anyway. It may be a little nicer where the raphe between the anterior and middle deltoid, but it's again the same approach. You go through the subcutaneous tissue, then you feel the lateral border of the acromion, and you got to split the whole thing. They expose all the way to the acromial edge to get a good exposure. You start from proximal side, you get to the deltoid area, subacromial space, and a lot of times people get kind of confused. What is the bursal tissue? What is the cuff tissue? Bursal tissue is much loose. Cuff tissue in a normal young healthy patient is pretty robust. So it's not easy to pull with a ronger or anything, but there's a layer of bursa everybody has. So you got to go through the bursal tissue to get the subacromial space and subdeltoid space. Then you can feel where the axillary nerve is again, where to expect. Then you dissect a little more distal. Again, if you're not going to use a plate that's caused below the level of the axillary nerve for a GT fracture, you don't have to do anything. But if you are fixing a 3/4 part that you're going to use a plate, you have to dissect this nerve a little more distal, and you're going to apply your plate. And the screws, the calcar screw that Dr. Mackey underlined a couple times in his talk, goes exactly where the surgical neck area is, right? And where the axillary nerve is. So you have to know where the axillary nerve is, and you're going to pull proximal and distal that you don't hit with that calcar screw that you have to put it in. Because the axillary nerve is there, not putting that calcar screw is not a good idea. So you still need to put that calcar screw, especially in various patterns. Thank you.